resonance imaging, you will see a spread as high as T45. It is, and I cannot explain that, but it is quite difficult to measure the dermatomal anesthesia as accurately as you can with an epidural block. I cannot explain that directly, but occasionally you can, occasionally you can't. So, but we only know that from MRI imaging that it can spread this high.
Thank you. And just before we get to your to the next questions, I want to ask Dr. Kamarkar a question. You showed, and I guess for the rest of the panelists too, you showed the picture of the patients who appeared to be under conscious sedation, having major thoracic and breast surgery, and I don't know what it's like in Denmark. I assume it's the same as at Duke as it is at Dartmouth. Most of our patients want to be unconscious for 3 weeks around their surgery, and their first memory going back home. So we do these things called tubeless generals. I don't know if you've heard that term. And I'm just, do you think this is a cultural issue, and do you think that's something that's applicable we could do in the United States to reap the benefits of these approaches? Because if we're going to the extent of essentially putting everyone to sleep, has some maybe some quality issues with outcomes.
I think, Brian, that's a very good question. I thought we were learning it from the Americans. Because many years ago, Dr. Greengrass, Roy wrote a series of papers on multi-level paravertebral blocks and breast surgery with improved outcomes. And so much so that I have been chasing this dream for almost 20 years to try and perfect this. Never succeeded until very recently, where we are now able to do very consistently multi-level paravertebral blocks. And we use sedation with dexmedetomidine. I actually started with propofol and fentanyl as they used to with combined with midazolam, but actually the anesthesia became more kind of a hodgepodge of anesthesia, as I often say, because patients often develop respiratory depression, they become apneic, and you've got to hold the mask, and so it becomes a bit of a mess. But with dexmedetomidine, I think we've had great success. We usually sedate them with midazolam, 1 or 2 milligrams at the moment. We place them in the position. We give them about 10-20 milligrams of ketamine because it's multi-level, so it causes some discomfort. Thereafter, we start the dexmedetomidine, but we do not bolus it. So the midazolam is like used as induction, and the dexmedetomidine catches up after a while. With this, we've had great success, and we do perform it quite regularly now, so much so. And we've also, we'll be pleased, I'm pleased to share this with you too, that often the question, you're doing multi-level injection, do you need 6 injections? I can share with you that you don't need 6 injections. 3 injections, alternate injection, as Dr. Abdullah or somebody had already shown, that you can get good spread. But again, multi-level paravertebral blocks on its own will not provide surgical anesthesia for breast surgery. Today we call them PEX blocks, so on and so forth. And that's why I think I have been chasing that dream of Dr. Greengrass et al. Is to be able to provide surgical anesthesia. And because we give them slightly lower levels of sedation, awake sedation, maybe in contrast to what they were more deeper, they never reported it. But we find that when the surgeon handles the pectoral muscle, patients often report pain. Today it's easy to understand because the pectoral muscles are not blocked by a paravertebral injection. You need to block the pectoral nerves, the lateral and medial pectoral nerves. Also, I'd like to share with you today, and I think my good friend Dr. Berglund mentioned, that we talk about the lateral and the medial pectoral nerve. It's actually a very simplistic way of looking at the pectoral nerves. The pectoral nerves form a subpectoral plexus. Makes sense? It makes a subpectoral plexus between the 2 muscles and deep to the muscles. So therefore, a single injection between the pec major and minor will not block the pec major, the lateral and medial pectoral nerve, in contrast to what my good friend Dr. Blanco says. You have to perform 2 injections, one between and one deep to the muscle. To hopefully, if you have adequate amount of local anesthetic, you should be able to. So that's what we do.
Deep to the pec major?
Yes, sir. Okay. So we inject deep to the pec major at the level of the thoracoacromial artery. Because the thoracoacromial artery is an important landmark where all the crisscrossing of the lateral medial pectoral nerves and the ansa pectoralis is happening. So if you just inject a local anesthetic at the level of the fourth rib deep to the muscle as described in the PEX 2, you may not be able to block most of the nerves. So at the same time, you have to inject adequate volumes. Today we find that you need to inject about 10 cc at each level. We started off with 5, but still about 50% of patients still reported some pain. So I think most of this data would soon be coming out as we are preparing manuscripts to describe.
Wonderful. Okay, I think we're